Okay, sir. So with all of your permission, we are starting our session. Good evening and welcome to one and all. I am Sneha from Clarnet, the dedication session assigned for the seamless experience of the session. Clarnet is very proud to be a digital partner for this event organized by the Indian Society of Pediatric Nephrology. And our today's topic is Module 5, uh, congenital disorder of the kidney and the urinary tract. So without further delay, sir, I would like to take this handover to Dr. Jitendra, sir. Over to you, sir. Kindly proceed for your talk.
Thank you, Sneha. Uh, Good evening, everyone. So today's session will be on approach to congenital anomaly of kidney tract. Before we, begin with the main talk, we'll have the pre-test related to this webinar. So link for that I'll be sharing in the chat box, and I've already shared. So participants, you can attempt. You would have 7 minutes, so it's currently 7 minutes past 7 p.m. So we'll begin the webinar at 7:15. So link I have shared in the chat box. You can attempt from there. I think it's already 7-8 minutes since we have started pre-test. We'll begin the webinar. So today's webinar will be again moderated by Professor Pankaj Hari and Lieutenant General Dr. Madhuri Kanitkar ma'am. And today's topic is, bit of wide spectrum of topic of, a umbrella of topic of CACUT, because CACUT can be varying from, small hydronephrosis to very severe congenital anomalies. So I'll now hand over uh, the session to today's moderators. Sir and ma'am, over to you.
Thank you, Jitendra. And I'm going to be moderating this session along with my co-chair, Dr. Madhuri Kanitkar. And we are going to talk about congenital anomalies of kidney and urinary tract, in short called as CACUT. It's an important disorder or renal disorder in children, and it's one of the leading causes of chronic kidney disease in childhood. That's why it's very important to be aware of this condition. Now, while it seems intuitively that it's a congenital anomaly, and so it's the job of the surgeon to deal with it, but interestingly, majority of CACUT, which are common, don't require surgery, or a very small proportion would require surgery. For example, antenatally detected hydronephrosis to vesicoureteral reflux. On the other hand, there are certain congenital anomalies that would almost invariably require surgery, for example, ectopic ureter or a posterior urethral valve. And so all this will be discussed initially as in the form of a lecture and then followed by case scenarios. And now I would invite my co-chair to proceed further with the rest of the webinar.
Thank you, Dr. Pankaj, and for introducing the subject today. And it's excellent that we've had this whole series, thanks to Jitendra and Aditi, who put together this program. And I thank all the delegates for joining in, because CACUT, like you correctly pointed out, for chronic kidney disease in this, but it's also in this symposium where we've had these series of urinary tract infections, urodynamics, enuresis, incontinence. I mean, this is now like the chicken and egg kind of a thing, which came first. And you will all agree that it's mostly either at birth or because of incontinence or because of a urinary tract infections that you'll end up finding that the child has a CACUT. And this can be individual or as a syndrome. And we have two excellent people who are presenting today. Like Dr. Pankaj mentioned, the first would be an approach to your CACUT. For that, we have Dr. Rachita Dul, who is Assistant Professor of Pediatric Nephrology at the Kalavati Saran Children's Hospital. And she will, after she finishes, we will go on to the case presentations. I'll request all this delegates who have joined in and people attending this course that please shoot your questions into the Q&A box, and the speakers or the moderators would be very happily side by side answering some of the questions, and the rest we would take on at the end as well. So with that, I hand over to Rachita. Please, the talk is yours now.
Thank you, ma'am. Thank you, sir. Thank you for giving me such a wonderful opportunity. So today I'm going to talk about the approach to CACUT. So as we all know, the learning objectives, my talk would be to develop an awareness for various congenital anomalies of the kidney and urinary tract, to develop an approach towards early diagnosis and detection of these anomalies, and to describe a little bit about the clinical presentation and management of common anomalies, including the timing and utility of imaging modalities. So as sir has rightly pointed out, that it is a major cause of kidney disease in children. It contributes to more than 40% of kids who are actually presenting with end-stage renal disease, so which is a huge number. And interestingly, these malformations are associated with non-renal congenital anomalies in approximately 30% of cases. So that's a huge number, where these malformations can also present with some non-renal conditions. So genetic and environmental factors both contribute to the expression of CACUT. So first, I would like to focus a little bit on nephrogenesis. I know it's overwhelming for all the students always to talk about development. So I have tried to simplify it. So let's take it stages by stages. So first stage we have is pronephros. So this is a rudimentary non-functioning kidney, which development begins around third week of gestation, and it has to disappear by fourth week of gestation. So degeneration is very, very important for normal development of the kidney. The second stage comes the mesonephros, which develops around 25 days of life. And the embryogenesis begins around fifth week of gestation. So what mesonephros causes, you can see 20 tubules which start producing little bit of urine. Ultimately, this mesonephros has also to go. It fuses with cloaca and leads to the formation of urinary bladder. So the main permanent kidney which is forms from metanephros. So this forms the permanent kidney, and two important components are ureteric bud and metanephrogenic blastema. So this begins around 5 to 6 weeks of gestation and functions at 6 to 10 weeks of embryogenesis. Urine production also starts around 9 weeks of gestation, and the active nephrogenesis, it occurs around 20 to 36 weeks of gestation. Around 36 weeks, we say that nephrogenesis, it ceases. So at the same time, it's very important to know that this kidney is actually initially lying in the sacral area. You can see along with the bladder. So that migration is equally important, with weeks, around 8 to 9 weeks, you can see it actually takes place. It's appropriate position, which is more in the lumbar region, not in the sacral area. So timing is very, very important. That's why I want to highlight these 5 weeks, 9 weeks, why these timing is important. So everything is happening in first trimester of pregnancy. So that actually is very, very important time when the development takes place as far as kidney is concerned. So pathogenesis, when we talk about pathogenesis of CACOD, it is multifactorial. And genetic and environmental factors, they play key role. If you look at on this side of the slide, you see there are multiple environmental, dietary, toxin, drugs, which contributes to the formation of anomaly in the kidney. At the same time, epigenotype and gene mutation, they play significant role. I'll talk about this later, but I just want to highlight that these two are the real players as far as development of anomaly in kidneys and urinary tract are concerned. So molecular control of nephrogenesis happen in a way that there occur a reciprocal interaction between the metanephros and the ureteric epithelium. That combines leads to organogenesis, but there are numerous players in this. There are signaling and transcription factors, their association with their receptor complex. I will show at every level these transcription and signaling factors are involved, which leads to development of a normal and healthy kidneys. You can see right from the induction level to epithelialization to the vessels involvement to PCT and DCT development. These transcription factors, as highlighted, these signaling factors, they play a major role. So if we have to identify these CACOD and according to the different stages, so if the insult occur in early stages of the development, so the kind of disorders which are caused are usually agenesis, hypoplasia, dysplasias, which you can see. If this occur little bit in the stage of ascent, fusion, then the anomalies like horseshoe kidney, ectopic kidneys is formed. As far as ureter is concerned, if it is not formed normally, then you have all these disorders, which are basically the abnormalities of ureter morphogenesis. So it depends according to which stage of kidney development is hampered, and according to that, you have a new CACOD developing. So if I have to simplify this for you in a simpler manner, what is a way to remember? So I find this little bit easier. So it talks in the form of like numbers. Say when you have absent kidney, it is agenesis. When you have extra kidney, it is supernumerary kidneys. When there is disorder of the size, it is hypoplasia. When there is disorder of differentiation, it is dysplasia. If it is not correctly positioned, then you can have horseshoe kidneys, ectopia, or malrotation. Or obstruction or non-obstruction leading to dilatation of the tract occur, it has these kind of abnormalities. So this is a more simplified, I would say, a classification of CACOD, just to highlight what common anomalies we can see in pediatric population. So I want to focus specifically on genetics because 20% of CACOD has inherited etiology. If you want to talk in the number sign, and I would say 40 genes have been isolated from the isolated forms of CACOD, and around 180 genes are there for the syndromic CACOD. And you will not believe that there are more than 200 genetic syndromes where there is a combination of Charcot with non-renal anomalies. So it's a huge, huge number. So I have just, these are the 5 pointers I would say everybody should keep in mind when to counsel these families, and when you can have little bit of suspicion that, this women can deliver a child with Charcot. So I would say, what are the clinical clues for monogenic Charcot is: 1, family history of kidney anomaly or there any kidney impairment in the family. Early onset is very, very important if there is early onset of kidney disease. Extra kidney manifestations if they are non-renal manifestations, syndromic features, and history of consanguinity. Always consider referring to a genetic counselor if you see these 5 things are present. So these I call as clinical clues of monogenic Charcot. Very important to remember. So since I already told you that the association is with more than 200 genetic syndrome, I have highlighted here some of the common syndromes that we see, like Turner's, Down, Patau, Charge, DeGeorge. All you can see that along with having a gamut of extra renal manifestations, they do have significant renal anomalies in the form of renal agenesis, renal hypoplasia, MCDK, VUR. These are commonly associated with these syndromes. So list is very long, but to highlight here, I've just named few common ones. So when we talk about what kind of extra renal manifestations we can see with monogenic Charcot, so in this slide, basically I want to highlight the importance that almost every organ is involved as far as extra renal manifestations. You can see right from your brain to your eyes, ears, heart, GIT, genitourinary, all are involved, which can, a simple gene affecting one place can also affect so many other places. So this is very, very important for us to know that if we are thinking about monogenic Charcot, it does have association with various extrarenal malformations. So always, always remember to screen the patient for all these malformations. So if we start the screening process, it starts antenatally. So antenatally, if I talk about screening, there are 2 most important components as far as screening of Charcot is concerned. One is a good ultrasound that we need, and second is assessment of amniotic fluid volume. So if you ask me what is the best time of doing a screening ultrasound to rule out these anomalies, is definitely when the usual anomaly scan is done, which is 16 to 20 weeks. You do start seeing, you have a good idea of how your kidney looks by 13 to 15 weeks of gestation. Urine production can also be seen in the bladder at the same time. But the proper differentiation that we always talk about, the cortex medullary differentiation in the kidney, that starts after 20 weeks of gestation. So the right time of doing is somewhere around 18 to 20 weeks of gestation to know better about the kidney morphology. So we need these 2nd trimester and 3rd trimester ultrasound basically for a good documentation of how well a fetal kidneys look, what is the status of urinary bladder, and at the same time we need a good assessment of amniotic fluid volume. So amniotic fluid assessment, why it is important, because we all know that urine production starts around 9 weeks of gestation. But by the time it reaches 20 weeks of gestation, almost 90% of amniotic fluid is coming from the fetal urine. So we know that if amniotic fluid is adequate, your kidneys are working fine. Also, at the same time, we know that normal fetal pulmonary dependent is dependent on this thing. So we need adequate amount of contribution from the urine towards the amniotic fluid so that the child should have normal, healthy lungs also. If you have oligohydramnios, which is amniotic fluid index less than 5 centimeter at this time, it should be carefully looked into that whether there is some urinary tract obstruction or not. Some people, they also do urinary electrolytes, sodium chloride and beta-2 microglobulins, just to assess the resorptive function of the kidney. When you have high, more than 90 MEQs per liter of sodium and chloride, so it means that fetal kidneys, they are not working properly. At the same time, if you have high concentration of beta-2 microglobulin or the urine osmolarity is less than 220 milliosmol per kg of water, you can think of that the function is not appropriate. So these are some of the markers that people look into amniotic fluid for assessing the status of kidneys. So when it comes to antenatal ultrasound, So what you should focus on. So the abnormal renal abnormalities I have highlighted here. So in the kidneys, what we have to look at, basically how well is the cortex formed? What is the good corticomedullary differentiation that we done? Are these kidneys really echogenic? If you see around 13 to 15, they are basically hypoecho at that time. So are they very echogenic, or there is abnormality in the form of cyst? So this is renal parenchyma, and this is basically for the collecting system. What is the status of calyces? How well a ureter looks? Is the bladder dilated? Is there any keyhole sign? So these are all marker of renal abnormalities on antenatal ultrasound. On the other side of these slides, if you see, these are the soft signs. These soft signs, basically, they are markers of different trisomies. You can see absent nasal bone, nuchal translucency, as seen in trisomy 21. So they basically point more towards syndromic cacket, where along with the abnormality of renal kidneys, you can also see some systemic abnormalities in the form of some genetic syndrome. So these are the things that we should have, when we read at 20 weeks of gestation, that we don't get to miss all these renal abnormalities, if any pointed out in a fetal ultrasound. So what happens when these child, they come to us in the postnatal period? We should have their detailed history and a good physical examination for all those who have some detected antenatally renal malformation problem. So then comes the role of the timing. Is early ultrasound really recommended for every newborn? No, it is not recommended. When to do early ultrasound? When you have history of severe oligohydramnios, there is progressive antenatal hydronephrosis, or there is bilateral severe hydroureteronephrosis pointing towards PUV or distended bladder. Otherwise, you can wait for first week of life. We know that at this time, urine production is not adequate. First few days is just reflection of your, maternal renal function. So we can wait. There is no hurry. At first week we can do, and later on we can repeat. I will talk about it later on at 4 to 6 weeks of life. But in these situations, all these 4 conditions, you should not wait. You should get an early ultrasound KUB to rule out any specific renal anomaly. So what happens if you have not followed this child in antenatal period? This is basically for those you have been following, you know that some kind of problem is there. But what happens in majority of our cases, patient directly land up in the postnatal period. We have never seen this patient. So in those cases, when you should suspect that this child might have some caquet, is either they have exposure to some kind of teratogen. I specifically want to highlight the role of ACE and ARBs if they are taken prenatally. This can lead to GJ apparatus hyperplasia, poor differentiation of PCT, medullary and cortical fibrosis. So can cause significant renal impairment in fetus. So at the same time, if you see anything abnormal in the physical examination, whether it is form of some coloboma, we all know coloboma is associated with renal coloboma syndrome, hemihypertrophy, like seen in Beckwith-Widman syndrome, preauricular skin tags, like seen in golden heart syndrome. So some kind of syndromes are associated with this abnormal physical examination. See, it's very easy sometimes to pick when some abnormality is available, child present with some kind of abnormal physical examination. At the same time, it can be sometimes non-syndromic also. So in non-syndromic, these all symptoms are not present. Then probably if you have some kind of exposure to teratogens, or only if you screen with the ultrasound or, do some blood test, you'll be able to find child definitely has some caquet or not. So after this, I would like to, describe a little bit about the common anomalies that we see. So beginning from unilateral renal agenesis, it is, as we all know, is the congenital absence of the kidney parenchymal tissue. It results from the major disruption which occurs at the level of metanephric development. It is more common in males, and left side is disproportionately affected. So this is a fetal ultrasound, and it shows that this is a liver and there is no right kidney. So this is a case of right renal agenesis. Unilateral reagenesis, at more than 30% of cases, they have some kind of other coexisting urogenital abnormality. VUR is the most common. So if needed, you should always screen with a MCU. Now you're left with a single functioning kidney, which definitely gets hypertrophied, hyperfiltrates, which leads to hypertension, proteinuria, and decline in GFR in later year of life. So monitoring for the same is very, very important. Annual screening for blood pressure, for urine protein, urine creatinine ratio in the urine, and also you should assess the kidney function. Every 1 or 2 years, you should get a renal ultrasound to make sure that the single kidney is growing well. At the same time, if somebody have bilateral renal agenesis, it severely hampered our respiratory development. So child has pulmonary hypoplasia, and severe form they cannot survive. So this is a typical case of Potter facies, where you can see there is a low set ears, beak, nose, epicanthal fold, pulmonary hypoplasia, and limb deformities. Another entity is renal dysplasia. So how dysplasia is different from hypoplasia, I'll also come to that. But dysplasia itself, the word means that there is abnormal differentiation. After the normal development has already started, the tissue has not differentiated well. But very important to know that more than 50% of the cases are associated with some other kind of urinary tract anomalies also. So if this has not developed, there might be some problem with this side also, for which we have to screen properly. So dysplastic kidneys, they are variable in size. They can be smaller, they can be normal, sometimes associated with hypoplasia. So we call them renal hypoplasia, dysplasia. The renal hypoplasia have to meet these clinical criteria. You have to have reduction of the kidney size by 2 standard deviation for that age. And for on DMSA, there should be no scarring. If you have ruled out this and otherwise that the size is less than 2 standard deviation, we called it hypoplasia. And most of the time, this hypoplasia and dysplasia, they occur together. So hypodysplastic kidneys, they are common causes of CACUD that we see in pediatric population. Ultrasound of dysplastic kidney, if you see, here is one kidney line, but there's hardly any corticomedullary differentiation. Very, very poor. You cannot differentiate which is cortex, which is medulla. Very echogenic. And sometimes you can see parenchymal cysts too. So what to follow in these patients? So if dysplasia is really bad, the function from that side of kidney will be very, very poor. Essentially, the patient will have one good functioning kidney then, unless it is bilateral renal dysplasia. And since I've already highlighted that more than 50% cases has some other form of urological anomalies, so definitely you should look for hydronephrosis, VUR, which can lead to symptoms like UTI, hematuria, fever, and abdominal pain. Prognosis basically depend upon the degree of involvement and associated urinary tract abnormality. So MCDK is another entity, and it is the most common cause of congenital solitary kidney. Most of these MCDKs, they involute 60% by the age of 10 years, but sometimes they may not. So this is one ultrasound. In antenatal ultrasound, you can see they are big, big cysts, which are not communicating with each other. And there is a parenchyma between, which is a dysplastic parenchyma. Intervening parenchyma is there. So there are 4-5 cysts you can see, which are not communicating. So MCDK can be detected antenatally also via ultrasound. Important to know here that contralateral kidney is affected in majority. Almost 30% population have some kind of involvement on the contralateral side too. If you see any abnormality on the ultrasound, I would say in the form of hydronephrosis, you should definitely rule out VUR, because around 15 to 28% they have VUR. And definitely you need, because it is non-functioning one kidney, definitely you need serial ultrasounds to monitor whether that kidney is growing well. And at the same time, we have to screen at least once a year for hypertension and proteinuria. Another entity is renal ectopia. Renal ectopia is basically abnormal location of the kidney. You see, both the kidneys should be here in the lumbar region. One is lying below its normal position. This can be simple when this, instead of being here, it's here. Or cross. Cross means it crosses the midline, and it can be on the same side or both the sides being affected. Simple ectopia, most common site is pelvic kidney, and it lies opposite the sacrum below the aortic bifurcation. What abnormalities it can have with it? Definitely, when it is not in the normal position, you can have abnormalities of ureter associated, leading to hydronephrosis. Yes, predisposition to UTI and stones are there, for which you should do a ultrasound and regular monitoring of these patients. This is the imaging IVP showing the renal ectopia, the pelvic kidney. This is a normal kidney here, and here is the pelvic kidney, which is lying much below its normal position. Cross renal ectopia is where both the kidneys, they are located on one side. You see that instead of being here, this kidney has migrated here, though its ureter has a normal insertion. But it came here, not only it has come here, it has fused also. So 90% of cross ectopic kidneys are actually fused. There are different forms of cross renal ectopia. One is with the fusion, one is without the fusion. This is just a single kidney. Instead of being here, it has come to opposite side. And here this is bilateral because both have crossed. Another entity which is similar to ectopic kidney, which is definitely the disorder of ascent and fusion, is horseshoe kidney. Horseshoe kidney is actually the most common congenital anomaly of upper urinary tract. It is found in 1 in 400 adults, more commonly seen in males. You can see that both the kidneys, they are fused at the lower pole. Either this is a tissue or a fibrous band which connects both the lower poles of the kidney. Majority of the time, this is on the lower pole only. This is an imaging which is showing the fusion of the lower pole of the kidney here. This is isthmus. Majority of these patients, they are asymptomatic, but some of them can present with abnormalities of such as uretropelvic junction obstruction, stones, and infection. So you have to screen them for this. If you see anything worrisome in the ultrasound, you can go ahead and do a MCU to see if they have associated reflux, or for function assessment, we can do a DTPA scan that will also tell us if patient has any significant obstruction also. There is a higher risk of renal lesions after abdominal trauma in these patients because of its location, and increased incidence of malignancy also. So just to highlight, just to cover, there are different anomalies of developing urinary collecting system too. If you see here, so this is, we have UPJO, which I'll discuss later on. So you can see obstruction at the level of pelvic ureteric junction. These two are complete duplication of the ureter. They have two different point of insertion. You can see the entire, there are two ureters here. This is complete. Incomplete is when both the ureters, they fuse at some point. Ectopic ureter is not inserted its normal site. Mega ureter, you can see the dilated tortuous ureter on this side. Out pouching, we can see in the bladder here, this is ureterocele. This is bifid pelvis. There are two pelvises. So these all are abnormalities of developing urinary collecting system, and they can lead to some kind of hydronephrosis. For this, imaging in the form of MCU or DTPA is required to find out whether they are associated with an obstructive cause or a reflux, and has to be treated accordingly. Antenatal hydronephrosis is actually the most common anomaly that is seen in antenatal or postnatal ultrasound as far as CACOT is concerned. So hydronephrosis is the most common abnormality otherwise. And fortunately, 40 to 80% is transient. So it goes on its own. But a significant portion, still close to 30%, can have obstructed cause, and 20% can present with VUR. So these numbers are very important for us to remember, that when to actually say that this child has antenatal hydronephrosis if APT diameter is more than equal to 4 millimeter in second trimester, or more than equal to 7 millimeter in third trimester. So we can remember these numbers. I'm not going into detail of antenatal hydronephrosis because we have a lecture in the coming week, but just to highlight, there are two different classifications. One is SFU and one is UTD. But the main idea is right from grade 1 to grade 5, if you see that the intensity of hydronephrosis, it keeps on increasing, and your parenchyma keeps on becoming more and more thin. So 1 to 5, the severity increases a lot. So this helps in basically, what kind of follow-up we should give to these patients and how long to follow up, and when intervention is required is based on the grades of hydronephrosis. So just to summarize here, I would say, again, highlight that all the cases of antenatal hydronephrosis or all the cases of abnormality, they don't need ultrasound right at the time of birth. So you can wait. only those 3 or 4 significant indications which I have already highlighted in cases where you actually anticipate that some kind of intervention can, help and save your kidneys, like in the cases of bilateral severe hydroureteronephrosis or progressive antenatal hydronephrosis, where you have to do early ultrasound. But otherwise, you can wait. You can do around first week of life and later repeat around 4 to 6 weeks of life, and actually you have a little bit more of your GFR. No hydronephrosis or mild hydronephrosis, they don't need any intervention. But moderate to severe hydroureteronephrosis, or you have any associated ureteric dilatation, then you need MCU, which can be done at 4 to 6 weeks. And if MCU does not show any reflux, you can go ahead and do a DTP or MAC3 scan, which can show you if there is an obstructed pattern or non-obstructed pattern. So otherwise, everybody does not need ultrasound right at the time of birth. VUR is an important cause that we see, which affects almost 30% of child who present with us with a febrile UTI. And primary reflux, we all know that this is an embryonic anatomical defect. And most of the time, it spontaneously self-resolves. So VUR is also most of the time a medical management we have to do. It's not surgical anymore. In the lower category of grades, we can just monitor with how many UTIs the child is having and put them on antibiotic antibiotic prophylaxis. And in the severe category, if child we can maintain on antibiotic prophylaxis for a long time, and only if they have recurrent UTI or we see that there is deterioration in renal function, we can go ahead and go for some surgery. But otherwise, most of the time, this is just managed medically only. So these are different grades of VUR. Grade 1 to grade 5, you can see the severity has increased here. 1 is just refluxing into non-dilated ureter. To 5 category, where is a gross dilatation in the ureter, pelvis, and calyceal system. And ureter, you can see, is very, very tortuous, and all the papillary impressions are lost. Secondary VUR is can also be seen in disorders. In childhood, we see neurogenic bladder or bladder bowel dysfunction. This can lead to secondary VUR also, where there is no anatomical defect. As such, in these cases, correction of bladder and bowel dysfunction help in resolving VUR in most of the cases. PUJO or called ureteric pelvic junction, UPJO. This is one entity where the role of surgeon comes into the play. This is an obstruction which is occurring at the level of from the renal pelvis to the proximal ureter. So you can see there is a huge dilatation there. So this is most commonly seen in males, and left-sided predominance is there. A big chunk, almost 10 to 30% of antenatal hydronephrosis, they present with UPJO obstruction. And patient can also present later in the life. Sometimes they present with pain, little crisis in the bone. This is the pelvis, and you can see the severe dilatation it is causing to the calyces. And here, the dynamic scan, it plays important role. We can see the obstructed pattern. A normal scan would be where the uptake is fast, followed by a rapid excretion, not beyond 10 minutes. But here you can see, instead of going this like this beautiful light blue curve, this purple one is going all together in the opposite direction and not coming down, showing severe significant obstruction, which requires surgery on that side. So to summarize for my disorders for CACUT, I would say there is a wide spectrum of disorders. I have tried to cover some of the common things that we do see. These are not only embryonic defects which are related to some environmental cause. Genetic also play a very, very important role. I would say that doing a genetic test is not required in all the cases. So you should always, see in the spectrum that what kind of kidney problem is this, how early it has. You can always take from those 5 pointers the monogenic clues that I have given for monogenic CACUT, the clues I have given, that when to suspect there can be a genetic syndrome. But sometimes this can be a non-syndromic also with a genetic predisposition. So we have to keep that in mind. So environmental causes and genetic both play a very, very important role in the normal embryonic development of the fetus. It is a major cause of end-stage renal disease. 30 to 50% of patients, it contributes to 30 to 50% of patients with end-stage renal disease. If we do a good prenatal ultrasound, we can very easily pick this. And when suspected, the role of nephrologists come into play with the prenatal ultrasound, that we have to decide whether this is something this child, should be consider continuing the pregnancy or not. Only in the severe cases we can think about things like termination, but otherwise most of the patients, they can go and continue their pregnancy. So a good prenatal ultrasound plays a very, very important role in this, in recognizing these patients at the proper time. When suspected post-birth, you should always do focal examination. Just don't stick on the kidneys. Not only seeing kidney, you should always see child as a whole. You can see there's so many non-renal anomalies which are associated with CACUT. You should always try to screen right from head to toe examination. You should screen from them too. And there has to be a multidisciplinary approach. It's not just a job of pediatric nephrologist. Equally, obstetrician getting a good prenatal ultrasound and timely, referring the patient to nephrologist is very, very important. And then nephrologists and urologists, talking with each other and taking a decision that when to operate, a timely intervention can really, really help and save these children. So I would like to end my talk here. Thank you, ma'am. Thank you, sir.
Thank you, Rachita. That was a real rapid fire, quick revision of the entire renal tract and its development down to the anomalies that we may find. I think, like we followed in the earlier things, we'll take the question answers at the end, though there's one typed out. We'll start with trying to assimilate this information through case scenarios. And for that, we have Dr. Anand Gupta, who's an associate professor at the Indira Gandhi Medical College, Patna. I request you to present the cases, Dr. Gupta.
Good evening. Rachita ma'am, please stop sharing.
Achha. Sorry.
Good evening to all. I hope I'm audible.
Yeah, you're audible. Please go ahead.
Thank you, ma'am.
Slides are seen.
Greetings from IGMS Patna. So thank you, Dr. Jitendra and Aditi ma'am, for giving me this opportunity. So after excellent presentation of Dr. Rachita, I will go through few cases which recently come across and describe the various spectrum of CACUT. So my first case is a 3-month-old male presented with abdominal mass on the right side. Actually, the child was diagnosed antenatally diagnosed to have right-sided hydronephrosis, but they lost to follow-up and came around 3 months of age. And mother noticed that there is slight palpable mass on the right side of the abdomen. All examination was normal, like the urinary stream was normal, there was no fever. Other finding and developmentally child was normal. So as a workup, we did the ultrasound and you can see this right kidney was calyceal system was dilated and it was size was 6.4 into 2.1 centimeter. Significant hydronephrosis, but ureter was not dilated. So this is important.
Can you please mute whoever's talking? Please, can you mute? Yeah. Please continue, Dr. Gupta. No, Dr. Gupta, you're not heard.
Hello.
Hello. Yeah. Now you're heard. Yeah.
Yeah. So this child ultrasound showing right-sided hydronephrosis, but ureter was not dilated. So one thing I would like to emphasize for our residents who are listening this, there's always ask your radiologist to comment about ureter, because normally ureter is not seen in very well in the ultrasound. So if ureter is not dilated and this pelvic calyceal system is dilated, so it's suggestive of hydronephrosis. So diagnosis was right-sided PUJ of 1 and APD diameter was 37 mm. So, and then DTPS scan was done. So it was suggestive of differential function of the side is 32%. And in the graph as just shown by Dr. Rasita, this graph purple line showing this obstructive pattern, because after giving furosemide, this graph should come down, because at the urine flow, this radiochemical element which has been injected should come down, but it's not coming down. So this is suggestive of right-sided hydronephrosis. So how to follow in this case? So as the protocol suggested in pediatric nephrology, so we can see, I'm sorry, on ultrasound and scan, if you see this, if this is not a single kidney or ultrasound and diuretic scan, if there is symptomatic flank pain, palpable kidney or UTI, hematuria or hypertension, then we should go directly with the pyeloplasty. If there is non-obstructive curve, then we should follow up in these cases with DTPA and ultrasound scan. And in partial obstructive or obstructive curve, we should see two things. One is a split renal function, that what is the function of right and left. If it is more than 40 and less than 55, and AP diameter is less than 22, then we should follow these cases with serial ultrasound and scintigraph. But if split function is less than 40% and more than 55, and AP diameter is 20, should go for pyeloplasty. Third condition, if there is very poor function, like split function is less than 10%, very thin cortex, then we should do PCN. In after PCN, if there is split function is improved, then we should go for pyeloplasty. If there is no improvement, then we can consider nephrectomy if the child has hypertension or recurrent UTI or that. If solitary kidney, then we should go for pyeloplasty. So our patient fall in this category. Split function was 32%, and so and APD was 37%. So child underwent pyeloplasty was done, and child is asymptomatic now. And repeat DTPA, which is usually done after 3 to 6 months, shows improvement in the renal function of 58 and 42% respectively. So second case is a 45-year-old male is complained of palpable abdominal lump for 15 days. The child was developmentally normal, anthropometric parameter was normal, and the child has no record of antenatal ultrasound, so we don't know whether it's about antenatal hydronephrosis. There was palpable smooth lump on the left side, mild para, and creatinine was normal. So ultrasound was suggestive of left-sided gross hydronephrosis. And in DTPA scan, the renal function was very less, as you can see, 3.32%. Almost there was no renal flow of pharmaceuticals, so there is obstructive pattern. So as we see in this graph, this comes in this category, a split renal function less than 10% or very thin cortex. So we do PCN, and nowadays it's very easy to put USG guided pictal catheter, and we did this and waited for around 2-3 weeks, and after that this renal function is improved to 30.84%, which was 3%. Now this is increased. We can see in the graph also. So as for algorithm, a split function improved after PCN, so the child is now posted for pyeloplasty. Coming to the third case, this is 4-year-old girl complain of continuous dribbling of urine along with normal void. 2 to 3 times she has normal void, but also there is continuous dribbling of urine. There is mild pallor, creatinine was normal. USG was suggestive of dilated right ureter, tortuous, maximum diameter is 3.65 with ectopic opening at the right vagina. So suggestive of right ectopic ureter. She also has a viewer differential function was 19%. So right ectopic megaureter was there and underwent right ureteric reimplantation. Ureter was found to be tortuous and large caliber. After surgery, symptoms improved and there was no dribbling. And follow-up DTP also shows improvement in the split function. It was now 31%. So diagnosis is right ectopic ureter. Our fourth case is, it's a very interesting case and it will show the importance of ultrasound. 5-year-old male child complain of right-sided abdominal pain On examination, a small lump was felt, creatinine was normal, and BP and all other examination was normal. So ultrasound is showing right-sided hydronephrosis. As we can see, there is dilatation of pelvic system. And one important finding, the right ureter was dilated, but there was a sharp tapering. You can see right ureter was dilated in initial part, and there was a sharp tapering. But this view junction is patent on the both sides, right and left. So that means there is no VUR. But ureter was dilated, so their diagnosis was right-sided ureteric structure. We did CT urography, and you can see this dilatation of the system, and there is a stricture in the right mid ureter. So child underwent surgery, and this intraoperative finding, you can see there is a stricture on the ureter. And after that, they put DJ stent, and you can see post-op ultrasound, there is right ureter which has decreased in caliber. You can compare this was the before this, and after this is decrease in caliber, and this white is a DJ stent. So this is right ureter with DJ stent in situ. And also you can see hydronephrosis has increased. The child is evaporated just 3-4 days back. Now next case is case 5, 6-year-old male child complain of pain abdomen for 1 month. On examination, developmentally normal child. Clinically, there is no finding. BP was normal and creatinine was also normal. On ultrasound, there is a hypoplastic right kidney and ureter was normal and left kidney was normal. And DTPA function, we can say this differential function of right kidney is 7.52%. So, and also you can see in this graph. So this diagnosis is hypoplastic right kidney in follow-up with BP and routine urine examination. My last case is 4-year-old male, which is follow-up case of multicystic dysplastic kidney of the right side. Presented with vague complaint of pain abdomen, clinically was normal, BP was normal and creatinine 0.6. In ultrasound, you can see this is the right kidney is small and left normal. We can see in MCDK, the most children undergo evolution of the kidney, involute kidney by 5 to 6 years of age. And DTPA also showing this function of 9.86%. So diagnosis was MCDK right kidney, and on the last follow-up, the child developed hypertension. So it started on ACE inhibitor. So my take-home message is Kakut has varied presentation, need teamwork with radiologist and ped surgeon or pediatric urologist. Regular follow-up is needed and good counseling is required so that the patient come for regular follow-up and remain in touch with the clinician. Thank you.
Thank you so much, Dr. Anand. You can, start sharing. We've had a couple of questions have not been answered. We'll take those first. But we've also had some which Dr. Pankaj has answered have been very interesting. We could also open those up for discussion, and I think that would take it forward. I think there was a very good question that what is the right time for early postnatal ultrasound of the KUB in antenatally detected hydronephrosis? So, would you like to answer that, Dr. Anand?
Yes, ma'am.
Yeah.
Ideally, if the child has mild hydronephrosis, there is no need to urgent ultrasound. But then, in case of moderate to severe, the ultrasound should be repeated after 3 days, after 72 hours of life, because we know at 72 hours, 48 to 72 hours, there is physiological diuresis in the newborn. So ultrasound should be repeated after 72 hours of life.
Yeah.
So,
I think that's correct.
Can I add, because see, majority of times you may not need an urgent ultrasound for a unilateral hydronephrosis, but if it's a bilateral hydronephrosis, or if you find the ureters dilated, then it's imperative because then you could be dealing with posterior urethral valve. And that is one of the indications for doing an early ultrasound. Otherwise, it can be done within the first week and then later on.
Correct. There's another question that Neha has said that I'm curious about the significant increase in differential function. I think, Anand, you presented a case with a management is increase in differential function. So she wants to know that is it sort of, generally we don't see that. You manage and there's a, so
No,
which are the conditions where, yeah.
Yes, ma'am. In my experience, whatever I have cases seen, if as already all taught by our teachers, and I am blessed to have Bhagga sir and Pankaj Hari sir in the panelist, where if there is any obstruction, the first aim should be to relieve. And usually, after relieving the PCN, I have seen improvement in many cases. So, like to tell the parent that this kidney is not functioning if there is obstruction, I think we should give a try to divert or go PCN and see the response.
Yeah.
I hope Pankaj sir can add more on this.
Yeah, I think Anand is right, but you can find sometimes, but very often you don't find an improvement. But the purpose of doing PCN is this, that you should, if there is a residual function, is there is a function which can return after relieving the obstruction, and you should give a chance to that particular kidney. And that is why maybe the function in your patient improved significantly after a PCN.
Yeah, I think that is important because what happens is, especially the timing. I mean, if it's not too delayed, it's a very tight obstruction. PCN is such an easy thing to do and see and improve it. And you know that definitely the surgery is going to have a good out. There's a question from Sana, choice of antihypertensive drugs in Kakut. Rachita, would you like to answer that? Is there any specific choice and why?
So if we think that this is something renin-angiotensin mediated, we can definitely go and use ACE inhibitors and aldosterone antagonists, I would say. But the literature on, somebody has also asked this question, is it safe to use in neonates? I don't think, I think literature is sparse, but definitely you can use, but at the same time, it's then, that the function is also evolving. You don't have the right GFR at this age, but still you can monitor, if you can look after, the creatinine, I would say hyperkalemia, all this can, I don't think so neonatal period is any contraindication for not using ACE and ARBs. So it basically, what kind of hypertension you are dealing with, and then you can definitely go and use ACE and ARBs. You can also use, very safe option is calcium channel blockers. You can use, you don't have to monitor also electrolytes and renal function along with that. So that what we routinely use. Ma'am can also add if...
Yeah, I think so. And
that's correct, actually. Yeah.
Captopril has been probably used a little more than the others. So that's okay. There's another question that what are your comments on overestimation of function on DTP and severe unilateral PUJO? Overestimation of function on DTP. In a severe obstruction. Any comments? Otherwise, I'll try to answer one of these. What actually happens is, in a very tight, obstruction, the retention and this thing is so much in the pelvis that you tend to get an over estimation. And at times, in fact, they even say a posture can change. So when you're doing a huge with a very floppy pelvis which is hanging out, it continues to show. Is there anyone else, Dr.?
Yeah, I think you're absolutely right, Dr. Kanitkar. We very often see this, that the kidney which has hydronephrosis is sometimes found to have a higher function, and that is predominantly because the radioisotope concentration there is overread because of the obstruction, because of the retention. And sometimes what they do is they look at the area of interest and they try to figure out whether this is because of extra, but otherwise it's not something unusual. That you may get an higher function as compared to the one which is absolutely normal kidney.
There's another question about in multicystic dysplastic kidney, like you have a non-functioning kidney, so it's like a single kidney status. Is it safe to use ACE inhibitors? Anyone wants to take this on?
Yes, ma'am, we can use, it's not a
with a single kidney and it's absolutely functioning normally.
Yes, but we just need to monitor a little bit more carefully, like potassium and creatinine where it is going, but otherwise it's not an absolute contraindication to it.
Personal attendee says, how would you prognosticate this? What is the this, if it can be specified? We can probably answer that. Is it related to the PUJ obstruction, or is it related to one of the previous questions. So I think those can just be specified. But otherwise, I think we've answered. Related to PUJ overestimation. Okay. I mean, once you've known it's overestimated, I don't think you would worry too much about the prognostication. There's one Sajanti, 2-month-old boy during neonatal period found to have bilateral grade 5 UR and moderate hydronephrosis, diagnosed as PUV, underwent valve, post-procedure urine stream and create normal. How long to continue antibiotic prophylaxis and do we repeat MCU? Dr. Pankaj, would you like to take that? Because we've discussed this.
Yeah. So I think if you look at the literature, if you go by the evidence, then you won't find much evidence to advocate prophylactic antibiotics in PUE. But if these patients have UTI, there is a history of UTI, then we definitely tend to give them. But there are some patients, believe me, who are PUE operated and they don't have a UTI at all. They perhaps then don't need it. So that's why you don't need to start in everybody, but surgeons very often would give prophylactic antibiotics. But with somebody who's not having any UTI, you may not give it. So it's not necessary.
And I think also what you correctly pointed out, and we discussed in a long way in the last thing on UTI, that there is a changing profile. Earlier, antibiotic prophylaxis was given very liberally.
Yeah.
We are very, specific about when to use that. So I think that is a question. Has any of the
about the MCU, I think is that ask another thing, whether MCU. So that it's entirely depends on the surgeon. I mean, if they are happy with the urinary stream and they see that the functions are okay, they are not suspecting any residual valve, they may not do it. But otherwise, sometimes when they suspect a residual valve, they would go ahead and do whether the obstruction has been removed completely or not.
Yeah. I think sometimes, occasionally, I've seen in practice, and I'd like Dr. Pankaj or any of the other speakers today to say that sometimes an antenatal, this thing, it looks like an obvious multicystic dysplastic kidney, but you do a DMS here to say, and there is some uptake. You do come across such cases? Is there any change in management for those?
So I would say no, because it is accepted that maybe up to 10% there may be some kind of a function in that kidney, but classically they will have zero function. They'll be non-functioning kidneys. But sometimes you must find some function, but then again it doesn't change the management in any ways.
Correct. I think you very nicely showed Rachita. I think that's a very nice rule about which ureter opens higher and which opens lower. No, when you have these duplications of a kidney on the side, it's always the upper one which opens lower up.
Yes.
So that's something which is very interesting, and that is very important, especially when you have a fused kidney.
Yes,
with the thing, then which one to remove, which one which is causing obstructing. I think that becomes a little surgical dilemma, and very often a pediatric nephrologist's opinion is sought for that kind of a condition. There's another question here. In antenatal hydronephrosis UTD classification, what's the rationale behind doing postnatal USG after 48 hours of life? Is it only because until it is a reflection, maternal, renal, or any other reason? Ultrasound, I think he explained, I think Dr. Anand took that question, because urine production is also very less in the first 40. So you may not really see the true, and it may be a collapse system. You may not pick up the postnatal hydronephrosis. So that is why we recommend wait for 72 hours unless it's like Dr. Pankaj clearly said, bilateral, where you're suspecting a PUV, severe ureteronephrosis also. Otherwise, you do tend to take it little easily. How frequent is bladder dysfunction in patients with obstructive CACUT? How long does it persist post-surgery and how to manage? Obstructive CACUT, I mean, not with the...
He means obstruction like posterior urethral valve.
Yes. So anyone would like to answer that question? Because we didn't really do valves today. We did it last time with the bladder and bowel. So possibly it was, this question was missed out, but definitely I think the bladder needs to be evaluated. Very often you find that a posterior urethral valve is operated but their obstruction has been long-standing intrauterine. So these children need to be followed up at least till the first 5 years with an ultrasound to see if there's a post-void residue. And how is the kidney? Is there any dilatation? Is there any creatinine? Because I think this is very important, because a valve which is ablated and child not followed up and comes back at 8 years, 9 years already with a advanced CKD. It's not unusual to find that. So I think I would say that definitely at least for 3 to 5 years. Dr. Pankaj, would you like to add
Yes.
some?
I think depending on the severity of PUE, there are some who may not have any bladder dysfunction, but a large majority will have some kind of a bladder dysfunction. It's very important to recognize that. And if you don't take care of that bladder dysfunction, you might initially have an overactive bladder, and then finally these bladders would go into myogenic failure. So it's very, very important. In fact, the whole thing, what is also called as a valve bladder, is very important to be managed and recognized. So it's a common problem in severe PUE obstruction, PUE obstructions.
So I think we've answered. There are no more questions. So should Dr. Pankaj, should we thank the organizers and tell them to take over?
Yes, yes, of course.
Dr. Jitendra, it's all yours again.
Thank you, ma'am. Thank you again for that excellent discussion and excellent presentation, Dr. Achita and Dr. Anand. Sneha, you can begin with the post-test now.
Okay, sir. So I'm launching the poll. Please let me know if it is visible or not. Is it visible?
Yeah, it's visible.
Okay. $20 left. $10 left. Thank you. Moving to the next question. $15 seconds more. $30. Thank you. Moving to the next question. $10. 20 seconds. 30 seconds. Thank you. Moving to the next question. $15 seconds more. $30. Thank you. Moving to the next question. Last 10 seconds. Thank you. Moving to the next question. Last 5 seconds. Thank you. Moving to the next question. Twenty seconds left. Ten seconds left. Thank you. Moving to the next question. Another 15 seconds. Thank you. Moving to the next question. Ten seconds. Twenty seconds. Thirty seconds. Thank you. Moving to the next question and the last question. Last 15 seconds. Seconds. Thank you. Over to you, Jitendra sir. Thank you so much.
Thank you, Sneha. So before we complete, today's session, I have important announcement for participants, because our national conference is approaching nearby in October second week. So there is some change in the original schedule which we have circulated to you. So in September second week onward, we'll be having a webinar on each Friday and Sundays because we want to finish it within September. So I'll circulate that modified schedule within 1 week to every one of you. So that's the important, change we had to make because of our national conference is approaching nearby. So our next webinar would be on next Friday on approach to antenatal hydronephrosis. Till then, bye-bye everyone. Thank you once again for joining us today.
Thank you so much, everyone. Thank you.